So what is your take about the assessment of patients, though, in terms of MRD assessment, and how are you doing MRD assessment in Cologne, for example? Are you using mostly flow cytometry, and do you want to go into how you're using this as a tool?
Yeah, so we so far also outside clinical trials, so it's not yet routine. We do flow cytometry. In trials we do PCR or even NGS. So I think as long as we don't take consequences from the MRD, it's always a question. It's of course additional information. It's a good predictive marker for the duration of remission after chemoimmunotherapy, also after venetoclax. In the best case, the patient has no detectable MRD by flow. But the question is, if the patient has detectable MRD, what are you going to do? Would that have an implication? Would you continue, for example, with venetoclax? Would you switch the patient from chemoimmunotherapy to ibrutinib? So therefore, it's really very selected patients where I do that outside clinical trials, because otherwise the patient is very much afraid. Yeah, very for the outcome, correct? Yeah.
I think it's probably important just to go over the assessment of the MRD, and they've been nice discussions here with using flow cytometry and using 6 or more colors to find leukemia cells that you can easily detect in 1 in 10,000 and going up to 1 in 100,000 if you have the patients. And now there's next generation sequencing that could potentially detect 1 cell in a million, provided you have the sequence of the B cell VDJ, the immunoglobulin gene, prior. And that could be a problem in that you have to have, prior to therapy, the genetic sequence to be able to look for it when you're doing response assessment. But all things being equal, you can easily get down to 1 in 10 of the 4, and the question is, how much is enough?
Exactly, but what is clinical? We still don't know if indeed MRD is just dictated the minimal by what's minimal feasible. Indeed, if 10 to the minus 6 is actually better than 10 to the minus 4, we haven't really seen that yet.
Yeah, that's a big important question. What does it mean to be high versus low? Now, in the Marano study that you played a very nice role in, there wasn't a chance to assess for high versus low MRD. And using the term, I much prefer undetectable MRD. I've had patients, for example, to tell them that they have no minimal residual disease. They throw away the crutches and they say, I'm cured. When in point of fact, it really is a limit of what we can detect. You're never going to be able to be more sensitive than the number of cells that you harvest.
True.
So regardless of the technique. And you're never going to be able to flay open the patient and see if there's any cells left. And there may be patients who have no detectable MRD who may still have aggressive disease that over time they will recur, and we see this.
They still have nodes actually,
and exactly. Although I must say, the nodes can be deceptive, and I know the iwCLL guidelines, which is a work in evolution, has used the lymph node size almost maybe to a fault, because I know the German CLL study group noted that patients may still have enlarged spleens and have a complete response, and we've actually had patients who had larger nodes as large as 2.5 or 3 centimeters after a therapy of venetoclax-based treatment. We couldn't find any leukemia cells in the blood or the marrow, and so the patient was gracious enough to allow us to biopsy the lymph node, and we couldn't find anything in it.
Exactly.
It's just scarring. So the size of the lymph node is one parameter, and I think it's imperfect in being able to define.
So actually in the HOVON study group, we're going to do now a phase 2 trial of ibrutinib and venetoclax, and then intensify if you don't get to an MRD negativity with obinutuzumab. And the interesting part of that trial is exactly to address that question. So what we want to do is we want to do PET CTs, very experimental, not for really to know what the biology is. And if we found any positivity, do a fine needle aspiration to indeed ask the question, those small lymph nodes, is there anything there or not? But I think we have no clue actually what it is.
Still need to have more information. Now, getting back to it, when you do MRD assessment, obviously patients would prefer that you do it on the blood, but there are some that argue that you have to do it on the marrow. Maybe you can explain your position on this.
Yeah, I mean, Andy Rostron has shown some data today that particularly after chemoimmunotherapy, there is a quite significant discrepancy between marrow and peripheral blood, but it could disappear if you use novel combinations, meaning ibrutinib plus venetoclax. There he suddenly saw that the peripheral blood is reflecting really nicely the bone marrow, but the numbers are small,
my simplistic take on it, that the anti-CD20 antibodies are very effective in clearing leukemia cells from the blood. And the half-life of these drugs is over a month. And so if you think about it, 3 half-lives or so after therapy, you still have considerable amount of the anti-CD20 there. Yeah. And it may give you the false negative if you just look at the blood. But if you wait long enough, 6 months to a year, there probably is greater concordance. So
you do specific for the CD20s, right? Do you think you have the same problem for ibrutinib and venetoclax combination?
I do, and we've seen that. I think that really is time dependent, and the reason that there was greater concordance in, for example, the Marano study, or even in the CLL14, is that in the Marano study there was a time-limited duration of rituximab, and when you did the response assessment, which is after a couple of years, the antibody is long gone.
Right, yeah. True.
So I think if you are probably outside of 6 months, then there's probably going to be greater concordance between the blood and the marrow. And patients prefer taking the blood sample and testing it. And if you find it there's no sense in doing the marrow to find it. Right. But if you have a year out of therapy with the anti-CD20s, the blood becomes actually a fairly good tool for doing that. Right. But I think we still have a challenge in being able. Now, what he was doing today was trying to say that if you have MRD that you can detect by very sensitive means in the blood, you might be able to use it because there may be a 10-fold order of difference between what's in the blood versus what's in the marrow. But that gets complicated.
Yeah, but I think in the end, maybe if you have just a decline of the CLL cells, if you have a graft, then you don't need the marrow anymore because it reflects already how your CLL burden is disappearing. Of course, assuming that we have a similar disappearance in different compartments.
It also depends, as you said at the beginning, how you use it. If you really use it as a decision, yes or no, to intensify or to stop treatment, then maybe you do need bone marrow. If you just need it to follow your patients, then maybe blood's good enough.
We had a very good discussion today about how the treatment algorithms for patients are changing in terms of defining initial therapy versus the treatment of patients who have relapsed and refractory disease. I think you had a very nice discussion today on this very topic, and maybe you can give your thoughts on how this is changing for the treatment of patients who are initially needing therapy. What sort of factors do you consider in terms of defining what choice of drugs you'd like to consider?
I mean, we heard today several talks about that, including the genetic factors, but there were particularly also presentations with respect to age and comorbidity. So how do we choose the cutoff for those patients, particularly when we still consider choosing chemoimmunotherapies? Does not play so much a role for ibrutinib. There you have to consider rather the comorbidity burden of the patient. And for the relapse CLL, we will discuss more during that meeting about that. I think that's a really more hard to treat patient population in the future. We don't know much about, we know something about resistance mechanism, but we do not know yet how to proceed when a resistance occurs to BTK inhibitor or to venetoclax.
It's a challenge, and that gets into treatment of patients who've had prior therapy, and I guess it depends on what their prior therapy is. So these newer therapies, patients with resistance to, say, ibrutinib, what sort of therapy considerations are you thinking about for your patients?
Yeah, so what we actually completely don't know, and probably we will never find out, is there a place for chemoimmunotherapy after targeted therapies, because we have no trials for that. So instinctively, a lot of people will now, I think, also in Europe, start ibrutinib first line. They probably will get their venetoclax as second line. And you will have for sure patients that will relapse after that. And then actually we don't know exactly what to do with those. And I was actually very happy to see, since I was like 15 years involved in CLL, that we hardly transplant anybody anymore. A very, very small number of patients, only when you get a Richter's transformation maybe. But I'm afraid if we don't do it well, if we don't design the studies well, that we start with ibrutinib, then we go to venetoclax, and then we might go to transplant again. So I'm a bit afraid that we are very happy now with all the new phase 3 trials of first-line patients, but what comes in 10 years from now?
So what sort of factors or things that you look at, though? You have a patient who has failed initial therapy. Do you still do your molecular testing or what have you? And so what sort of tests do you like to get, again, before you give patients therapy?
I mean, if we come to the point one day that everyone is getting ibrutinib, we don't have to test anything. But that's also not true, because we also, as discussed before, we know that there are patients who respond long and not so long to ibrutinib. Yeah, so far it's still the genetic parameters which are very important also for selecting those small patient population with high-risk features not responding very well. We still may go to allotransplant for those patients.
Yeah, I got a big question in the working groups, I think, is now also that if you have ibrutinib failure, you go over to venetoclax. Will you, in young patients, use that as a bridge to an allo, or will you just keep on venetoclax for 2-3 years and wait for what happens?
What sort of parameters would you look at that would make you think of allotransplantation?
Yeah. So maybe it's not good to say that on television, but I think it's not in the guidelines. But for this, I think MRD can be very handy. If you see that the patient does not become MRD negative on venetoclax after 9 months or say 2 years, according to the Murano study, then I'm more intended to worry than if he's MRD negative, if he's undetectable MRD.
Recommend transplantation for such patients who have had a fairly good response but still have MRD?
Well, depends also, maybe it's complex, depends also on the complexity of their genome. So if it's a complex patient with non-MRD, with really MRD positive above the -2, we know from the Murano study that the duration of remission will be shorter. And because we don't know exactly how to treat the patient after that, there is discussion going on here. Do you agree on that?
I think, I think transplantation still is playing a useful role, particularly in patients who develop a Richter's transformation. There are protocols that we're testing, and I know that you are as well, where you can achieve a fairly good remission with Richter's in many patients. But I think history would say that the remission might not be long-lasting, and getting the patient treated either with transplantation or CAR T-cell therapy, which we're going to have some discussion on during this meeting too, might be appropriate to consider, particularly for younger patients. So I think that in terms of a lot of discussion, this real-world data, they keep bringing this up, but what is the real world, and who lives in the real world? I think it's clear that what we do in universities may not be practiced in the community, and I think we have to be careful not to make things so complicated that it's difficult to sort out what to do in a difficult clinical situation. And I think it's probably important that we try and be clear as to what the parameters are that we would most like to be tested in the community. And so what would your recommendation? I'm here a community doc and I have a patient with CLL. What would I do before I give initial therapy in terms of the types of tests I should get? And what should I reach for in terms of treatment?
I'm still consistent with, I would definitely test for TP53 and IGVH status.
Okay.
And then discuss with the patient.
And Arnon?
Yeah, I actually agree. We do the cytogenetics, specifically DEL17P and P53. One thing we made pretty harsh in the Dutch-Belgium guidelines is that a lot of groups, a lot of laboratories say they can do P53 mutation status analysis, but there are also those results are now so important, specifically when we really decide treatment on that we now very strongly recommend to only do that in certified labs, and we use this IWCLL certification because we know that there can be a lot of discrepancy and you can actually misnominate P53 mutations that are actually not relevant.
Of course, if they have P53 mutation or deletion 17P, you would not recommend chemotherapy.
Right.
And I think that's clear, and I think it's understood. And you would also do the same thing with relapse patients in the real world, and hopefully patients can at least be spared chemotherapy who have that type of characteristic.
And what about CT scans? I think there was in the iwCLL and in the guidelines that you wrote, there's a lot of debate if you should or should not do CT scans. We also discussed yesterday. What do you?
Well, CT scans, I remember seeing a patient who came for referral and they had a CT scan every 3 months, and I could just flip it like a movie. And I think that oftentimes patients may be subjected to too many CT scans, and it's challenging to know how they improve our ability to assess the response to treatment or predict outcome. But unquestionably, in the context of trials or when we're trying to assess for things such as tumor lysis risk in patients who are going to take drugs such as venetoclax, it could be very useful to find out what the CT scan is. So I think there's still a role for CT scans. I think this has been an excellent discussion. It's very good to be here, and it's excellent to be able to be with such sharp colleagues, and I hope you can get some idea of the excitement that exists, and even among the experts, there's still a lot of things that we need to explore and understand that only could be determined through clinical trials, and there's certainly still a lot of work to be done, but a lot of promise for patients with this disease.